it gives me great pleasure to introduce Dr. Forrest, who not only is a colleague, but also a friend. And what I will do after after Dr. Forrest speaks, we'll open it up for discussion and some points. I don't think it's going to be really a debate, but sort of a coming together more in the old-fashioned way of how the Senate used to be. So, John, yours.
Stan, thank you so much. I hope everyone can hear me. If you can, let me know. Tom, it's always great to see you. And you know, this is actually, I didn't know about this Michigan TAVR collaborative. It's really impressive what you guys have been able to do. I didn't know exactly what it was. I wasn't sure if it was a collaborative that extended beyond TAVR into other things within Michigan. So maybe not there yet with Michigan and Michigan State. Maybe not quite there yet with TAVR versus SAVR for bicuspid aortic valves, but I will do my best shot here. Here are my disclosures. So just really as a background, you know, early studies with patients with bicuspid aortic valve undergoing TAVR using primarily early generation valves demonstrated lower device success, increased stroke, increased paravalvular leak, and increased need for a second valve as compared to patients who had trileaflet aortic stenosis undergoing TAVR. That being said, more recent retrospective data from the TVT registry has demonstrated that patients with bicuspid valves who undergo TAVR with current generation valves have outcomes similar to matched patients with trileaflet valves. This is some of the data that we have looked at. However, there really have been no patients with bicuspid valves who have been included in any of the randomized TAVR studies that have been done. Patients with bicuspid anatomy do present up to 50% of low-risk patients in whom aortic valve replacement is performed. And the primary, sorry about that. And in our low-risk study, actually, the primary outcomes, which were 30 days, demonstrated excellent results in low-risk patients undergoing transcatheter aortic valve replacement. We now have data out to 1 year from that. I'm going to present some of that 1 year data and then get to talk to some of the points that Tom brought up. So the low-risk bicuspid study was a prospective single-arm study that enrolled 150 patients at 25 sites across the United States. One of the actually issues with the TVT registry, and I think you guys are dealing with that with your Michigan registry as well, is we don't capture Sievers classification in the TVT registry. And so this is one we did for this study, capture Sievers classification, and all of the echoes were reviewed by a core lab. And so for this analysis, 150 patients from the low-risk bicuspid study were propensity matched to patients from the low-risk randomized TAVR study who had TAVR. We used a matching mechanism, and patients were matched based on age, sex, STS score, a number of cardiovascular risk factors, and the size that they had there of their valve. I think it's really important to look at not just the patients who were in the study, but the patients who actually dropped out of the study or weren't included. And what you'll note here is that there were 60 screen failures. The majority of them were for patients for anatomic reasons. 17 had a tricuspid annulus. There were 9 patients who had an ascending aorta greater than 4.5 centimeters, which is obviously an indication for surgery. Patients whose sinus of Valsalva was too small. There was actually of note only 1 patient who was excluded for prohibitive LVOT or leaflet calcification. And you'll note in this study that it required patients to be 60 years of age or older. There was actually 1 patient who was younger than 60, and so was excluded by the screening committee. So we started with 150 patients in the bicuspid arm and the low risk, and then 730 from the Evolute low risk study who were eligible for matching. And we ended up with 145 matched patients of both. When we looked at the baseline characteristics before matching, you'll see some differences here. The bicuspid patients tended to be a little bit younger. There tended to be more females with the bicuspids. And interestingly, the patients who had tricuspid valve disease had more coronary disease. And there's actually been some evidence that's come out there that has shown that the mechanisms for aortic stenosis in trileaflet patients are similar to that where you get coronary disease, whereas bicuspid, it's a little bit different. Here you can see the procedural data from the matched patients. The majority of the patients undergoing TAVR with either a 26, 29, or 34 millimeter Evolute Pro valve. And there are some differences here. You can see pre-implant valvuloplasty was performed much more commonly in patients with a bicuspid valve. And in fact, in this study, it was mandated that that be done. You can also see cerebral embolic protection because the bicuspid study was started after the Evolut low risk trial was done more frequently. And you can also appreciate that there was more than one valve implanted, a little bit of a higher frequency of time there. If we look at device success, it was excellent for both the bicuspid and the tricuspid patients. And if we look at clinical outcomes, you'll see here at 30 days and here at 1 year, really no significant differences in clinical outcomes. Again, this is looking at TAVR and low-risk patients, whether they have a bicuspid or a tri-leaflet valve. Rates of all-cause mortality, disabling stroke, all quite low. And when we look at our hemodynamics, what we see here is, the excellent hemodynamics we've come to expect with a self-expanding supraannular valve. And hemodynamics that, to be frank, are significantly better than what we see with surgery. To the extent that that makes a difference over 5, 10, 15 years, we'll have to see. But we do know from the surgical data that the better the hemodynamics you have at 1 and 2 years, the longer the valve tends to last. When we look at paravalvular regurgitation, certainly not as good as surgery, still a good number of patients, right, at 1 year who have none or trace, almost 80% of patients, about a little over 20% of patients with mild, and there was one patient with moderate paravalvular leak. Sorry, these slides looks like they're advancing on their own. I will note from this that, we know moderate paravalvular leak is bad. The outcomes of mild paravalvular leak, I think, are still up for a little bit of debate. I think those probably fall more into the areas like moderate paravalvular leak and a little bit of better hemodynamics. How do they balance each other out? We certainly know that all bicuspid valves aren't created equally. This is some work from Raj Makkar and his colleagues looking at the calcification of the bicuspid valve, whether there's not a significant amount of excess calcification, whether you have either a significantly or excess calcification on a leaflet or a raphe, or whether you have it on both. And certainly there are significant differences in outcomes based on the amount of calcification that you have there. And so in summary, I think we can say that the presence of bicuspid versus tricuspid valves doesn't impact results in low-risk patients at 1 year undergoing TAVR. Patients with a bicuspid valve frequently underwent implant pre-valvuloplasty with no significant difference in post-dilatation or stroke. Women accounted for about half the patients in this analysis, and patients with bicuspid valve had very, very low rates of greater than mild paravalvular leak, less than 1%. Hemodynamics were similar for bicuspid and tri-leaflet patients and were significantly better than they were with surgery. So the presence of a bicuspid valve does not appear to impact early outcomes in low-risk patients undergoing TAVR, specifically here using a self-expanding valve. And I think it's fair to say that when performing TAVR, the impact of calcium distribution probably is going to impact your outcomes more than the number of leaflets. And I think we'll spend a little bit of time here. I wanted to get through these slides just so we can talk some, but I think the results of the low-risk trial and the bicuspid TAVR studies can't be extrapolated to all patients. And I think this really gets to Tom's point there. We're talking here, we're not talking about patients who are 55, right? We're talking about the average age of the patients here is 70 or 72. So I think in those patients, there isn't really a discussion, should I have a mechanical valve or a non-mechanical valve? I think if you're talking about having a mechanical valve, obviously surgery is going to be the right thing. But if we want to sort of compare apples to apples and talk about bioprosthetic valves and not replacing the ascending aorta, I think there the question of, is it reasonable to do a TAVR as opposed to a surgical aortic valve replacement in a low-risk patient where we would just be replacing the aortic valve with a bioprosthetic valve? I think certainly the early data suggests that's quite reasonable. Dr. Gleason's points are very well taken. I think we'll have to see really what longer term impacts things like better hemodynamics or mild paravalvular leak or increased pacemaker rate have over the long time. And the other thing I really want to highlight here is that, and I think we see it with the Michigan data that you showed, which is so wonderful you guys are collaborating like that, is that heart teams are doing an excellent job understanding which patients have anatomy that's going to work for TAVR when they have a bicuspid valve. And for places that aren't doing bicuspid valves, I don't think you can just open up the floodgates and say, okay, now we're going to do all patients who have a bicuspid valve because here's the data and it works great. The fact of the matter is, the role of the heart team, understanding TAVR anatomy that's suitable when you have a bicuspid valve and not suitable is the key here. And when you pick valves that are suitable, you're doing an outstanding job. And so what I'll say is that in our practice here at Yale, when we have low risk patients, but who are over the age of 65, certainly over the age of 70, we really tend to use 70 more than 65, who are over the age of 70 and have a bicuspid anatomy, we look closely at it. And if they have anatomy that's not heavily calcified, right, that's raphe that are fused, but there's not excess leaflet calcification, they have sinuses that are good enough, they have good coronary heights, then we're very comfortable doing TAVRs in those patients. The fact of the matter is, though, that bicuspid anatomy more frequently than tricuspid anatomy, you're going to have an aortopathy, or you're going to have excess leaflet calcification, or you're going to have very low coronaries. And in those low risk patients, they would have been excluded from these studies. And I would argue they should be excluded from having TAVR at any of our centers. They should still continue to have surgery. So I appreciate everyone's time.